Good morning, good afternoon, good evening, clinical problem solvers. It's Tuesday. It's Neurology Morning Report. Woo! Try to incorporate some Robbie and Reza sounds into my introduction to get people excited. So we have a case from our good friend Rafa this morning. I see Doug there. Doug probably has 1,000 cases also. If we finish too early and want thousands more cases from Doug. And if someone also brought a case that they were hoping to present, we can save Rafa's for another time. So did anyone have a case they were hoping to present, and who would like to discuss? Ideally, one identifying as a woman and one discussing identifying as a man. Who would like to join us? Oops, was I on mute? I was asking if anyone would like to volunteer. I know, Doug, this is part of my new stand-up routine. Doug's hanging on me.
You're killing.
Oh, thanks. Thanks. So who would like to discuss the case this morning? Maybe you're thinking, I didn't realize it was going to be Neurology Morning Report. I thought it was going to be a case of renal failure. It's not a case of renal failure, though that could cause all sorts of neurologic symptoms. And so you might be thinking, I would have discussed if it was medical, but neurology is part of medicine, so it'd be great to have you discuss. Maybe you're thinking, well, English isn't my first language, and so I'm not 100% sure. Well, we have Spanish and French and Portuguese and German and other speakers of various languages here. Valeria, fantastic. Frequent discussant, glad to see you. Who would like to join Valeria in this discussion? All right, let's do our usual strategy here. So I think Rafa is presenting, Maria and Gabby are scribing and teaching points, Valeria is discussing. If you all want to introduce yourselves, tell us where you're from, and I'm sure someone will be so inspired to want to join you.
Sure. It's been a while since I have discussed, and so yeah, I'm really happy to be here. I'm Vale. I'm from Lima, Peru, and I love neurology thanks to VMR. So really happy to discuss today. So please volunteer.
Yes, thank you, Valeria. We always love having you present cases and discuss. Other friends, want to introduce yourselves? Valeria is still awaiting her partner in discussion this morning.
Hi everyone, I'm Gabby, I'm from Brazil, and I'll be scribing today, and it's gonna be fun. You should join Vale and Aaron in the discussion.
All right, 2 plugs. We're counting on you, Maria and Rafa.
Okay.
I'll go first. So that Rafa gets all the pressure if I don't get any volunteers. I'm Maria. I love neurology. I'm gonna be doing teaching points, and I don't know if I never get any volunteers. So Rafa, you go.
It's
cumulative. Oh my God, the pressure is high. Hi everyone. My name is Rafael, and I'm a medical student from Brazil. Oh, please volunteer. It's always fun to learn from and I promise you, this is a very simple case, but very educational.
Famous last words. It's a simple case. One more discussant to join Valeria.
Hello, guys. My name is Boris. I'm from Russia, Moscow. Nice to meet you.
You'd like to discuss the case with us, Boris?
Yes, I would like it the first time when I visited your Zoom conference. Of course, yes.
Fantastic. Welcome, Boris. Glad to have you joining us. And we have so many continents represented today. I love it. So Rafa, give us just the chief concern, chief complaint, and we'll get off to the races here.
Okay, so this is a case of severe headache and neck pain.
Severe headache and neck pain. So Valeria, what comes to mind when you hear severe headache and neck pain?
Yeah, sorry, my Wi-Fi is glitching. But what I'm thinking with headache is definitely first differentiate from primary and secondary headache. And so I will look for red flags. We know there's pneumonic, thinking about systemic symptoms such as fever, and in this case, neck pain. thinking if they could mean some kind of subarachnoid irritation, if this sudden neck pain, maybe thinking about a hemorrhage, or if it's something with fever, for example, thinking about meningitis. And other systemic symptoms such as weight loss, and then neurologic findings such as focal deficits that could point out to something secondary occurring. Then also like positional changes, if it changes with position of the headache, if the patient is immunocompromised, or if they're pregnant, for example. Yeah, I think also the onset, if it's sudden, if it's the worst headache of their life, like the thunderclap type headache, that would definitely be an alarm symptom. So yeah, I will definitely ask for those questions first to see if it's a primary or secondary headache.
Fantastic discussion as always, Valeria. Right, so our first question here is going to be whether this is a primary headache disorder or a secondary headache disorder, which you explained beautifully. A secondary headache disorder meaning the headache is arising from some other condition that we can name, whereas the primary headache disorders are conditions like migraine headache, tension headache, cluster headache, which are syndromes that are well characterized and probably have some pathophysiology that we don't fully understand, but they don't have a clear underlying cause. And what would those underlying causes be in secondary headaches? Valeria gave us a nice list. I grouped them into conditions that are inside the head, conditions that are of the head and neck, and conditions that are systemic, right? So what's inside the head, the brain doesn't feel pain, but once you get problems in there, they can affect other structures that cause pain. So things related to the brain tumors, hemorrhages, etc. And then other things that are inside the head, the meninges, so meningitis or subarachnoid hemorrhage irritating the meninges, both of which Valeria mentioned. And then things that are of the head, but not inside the head, is anything. So you can have ophthalmologic problems, you can have sinus problems, dental problems, problems of the cervical spine, problems of the cervical arteries, all of which can cause headache and or neck pain. And then you have systemic conditions. We all have had a headache with a viral infection, or if you've had your COVID vaccine, there's a pretty bad headache that came with that for me. And I wondered, what is that? Are my meninges slightly inflamed, or am I dehydrated, or what is that actually causing pain in my head? I don't know the answer to that. But so secondary headache disorders inside the head, of the head and neck, or systemic conditions. And then, as Valeria said, we want to use the history to try to get a sense of whether there are any so-called red flags, which are aspects of the history that would make us more concerned about one of these secondary disorders. So she mentioned if it was a sudden onset or thunderclap headache, we would think about vascular conditions like subarachnoid hemorrhage or vasospasm, other conditions like that. If there's fever, that would be a red flag to make us think of meningitis, encephalitis, abscess, things like that. I'm going to start listing things. I don't remember if you said them or not, but those are some of the big ones that you mentioned. Context as well can give us red flags. Does the patient have cancer? We could worry about metastases. Does the person have HIV or another cause of immunocompromise? We could worry about opportunistic infections, and so on and so forth, right? On the other hand, if there are no red flags, we're trying to use kind of syndromic clues to say, oh, this has some of the features of migraine, or this has some of the features of tension or of cluster. So those are some of the many considerations we'll be listening for in the history. There's probably one other category of sort of red flags. You mentioned ones related to vascular, ones related to context. This is sort of a guess what I'm thinking, but another set of red flags for a particular set of headache causing conditions. Any thoughts on, sorry for a guess what I'm thinking question, but Valeria or Boris, another sort of aspect of the red flag questions you might ask? And you might have mentioned this, Valeria, but I don't remember. I don't think so. What about if the patient says the headache is worse first thing in the morning, the headache wakes them up at night, the headache is worse with coughing, sneezing, and or straining? What kind of red flag would that make you think about? Any thoughts, Boris or Valeria? Those clues in the history? Did we lose Valeria? Oh no, I think we lost Valeria. Hopefully she will find her way back. So those would be clues for elevated intracranial pressure, right? So the intracranial pressure is accounted for by three things: the brain, which is about 80% of intracranial volume, the cerebrospinal fluid, which is about 10%, and the blood, mostly in venous structures, which is about 10%. So normally all of that is in nice equilibrium, right? So when you lie down at night or when you do a headstand in your yoga practice, you increase the amount of CSF that's normally in there, and that's okay. There's space for it, and venous structures can collapse, and nothing is compromised. But if there's elevated intracranial pressure, when you lie down and eliminate gravity, and all that CSF that's been hanging out in the spinal column comes back to the brain, this is what I call brain orthopnea, right? When you're lying down, just like the heart, all the venous return comes back, and if there's heart failure, the patient spills some pressure back into the lungs. Similarly, if there's too much pressure in the brain when lying down, the CSF there will sort of tip things over, and the patient can have a headache that's worse over the course of the night, or can wake them up in the morning, or that's worse with any sort of straining. So those are other sort of red flag clues we've mentioned. So Maria has categorized these beautifully in the teaching points. The red flags are either related to the characteristics of the headache itself in terms of onset, timing, aggravating factors, et cetera, or the context of the patient, right? Immunosuppression, cancer, mentioned pregnancy, lots of different ways you can get a headache during pregnancy, but certainly things we could worry about would include venous sinus thrombosis, other aspects there. So great. We saw you disappeared, Valeria. We're glad you came back. We're still talking about the chief concern and mostly just summarizing fantastic things that you said. Okay, so let's hear some more of the HPI, Rafa, and then Boris, you can tell us what you think of that.
So this is a 35-year-old woman that comes to the emergency department due to severe headache and neck pain following a motor vehicle collision. This patient denies dizziness, blurry or double vision, slurred speech, numbness, or weakness. And that's the end of the article.
Okay. Do you want to provide us the past medical or any of those things, or you don't have to? But
No. I think you're good to go.
No, okay. Here's what we have, Boris, a little more information. What are your thoughts here? Are you still there, Boris? Did we lose Boris? No. Not a good day for global Wi-Fi. Boris, are you still with us? I see you. If you're talking, you might be muted. All right. Valeria, do you want to keep going on the HPI? And we'll hope Boris will come back in time to discuss some other things. What are you thinking after this history?
Yeah, well, with the history of a collision, a motor vehicle accident, definitely thinking about something that could be traumatic and a hemorrhage. I think if I was on the ED with this patient, I would definitely go for a non-contrast CT to rule out a hemorrhage. And the neck pain, I mean, I'm not sure if the neck pain could be because of the trauma. I would like to know if it was a huge accident or if it was minor, to see if, what are the possibility of it being a big hemorrhage, or the neck pain because of the impact or because of the hemorrhage. And then I'm not sure, we don't see focal signs just yet because we don't have the exam. I think I would also like to see if there are signs of intracranial hypertension, like edema, which will also be a great red flag. Yeah, I think that's what I would do next.
Yeah, I agree with you. So certainly, sometimes a patient has some type of inciting event or trauma, but then the symptoms they present with could have nothing to do with it, and they're just sort of discovered because the patient is now in the hospital being seen by a neurologist. But that doesn't seem to be the case. You're right, we have symptoms that have begun essentially contemporaneous with this accident. We would want to know a little bit more about it, or maybe the patient will say actually they had a headache for days and now it's worse or something like that. But as far as we know, this is trauma, and then that's the ictus of this symptom. So certainly, as you said, we would be worried about traumatic intracranial hemorrhage, which can be in any compartment. Subarachnoid, people always think, oh, that's from aneurysm rupture. You can get traumatic subarachnoid hemorrhage. It tends to be more in the called convexal or sulcal subarachnoid hemorrhage that sort of sits in the sulci as opposed to the aneurysmal subarachnoid hemorrhage that everyone knows from exams, looks like a star in the basilar cisterns. So you could get traumatic subarachnoid hemorrhage, you could get a traumatic subdural hematoma, a traumatic epidural hematoma, a traumatic intraparenchymal hemorrhage called a cerebral contusion. All of those are possible. And so given the patient's symptoms, there are decision rules for who needs a CT after head trauma, but I think in this case, it would be hard not to get one. You mentioned looking for papilledema, which is always a good idea, but papilledema does take some time to develop. So some people get tricked on this. If a patient has chronic headaches and you look and you say there's no papilledema, that is relatively reassuring. But in the acute setting, say a patient with maybe a venous sinus thrombosis or something like that, and the patient has symptoms just for a day or two, you might not see papilledema yet. So you don't want to be falsely reassured. Good. So certainly intracranial hemorrhages of various in various places we would want to consider. Any other thoughts, Boris? Are you still there? Or if anyone else wants to volunteer, if we lost Boris here, or Valeria and I will just go back and forth. It's also fine. Other things to think about. So we do have neck pain. If we just thought of mundane things, Rafa tried to bias us and say it's a really simple case. Did the patient just bump their head and get some whiplash in the car? That would be simple. And that's probably one of the most common things we would think of here. And the head and neck are connected, right? So patients can have what's called a cervicogenic headache, where lots of different pathologies in the neck, but cervicogenic, I think classically from degenerative disease of the cervical spine, can cause referred pain to the head as well. So other things that could happen here, I guess it's just you and me, Valeria. Other things that could happen traumatically to structures in the head and neck that could cause head and neck pain?
Well, I was thinking about what Doug and Gabby were pointing out, the possibility of a vertebral lesion. And I think Gabby's question is really great because the patient doesn't have any focal neurological signs. And I also, with vertebral dissection, I always thought that, you know, we will find focal neurological deficits. And so what are your thoughts on that?
Yeah, good to think about a cervical artery dissection, either carotid or vertebral. Those are commonly caused by trauma, although sometimes the trauma is so minor the patient doesn't remember it. Or you sort of pinpoint something, but you're not sure. I had a very memorable patient who didn't have any trauma, but he was a carpenter and did a lot of work in houses. And we think probably from some neck position. I had one patient who the residents presented this patient as a vertebral artery dissection after skiing. And we thought, oh, it must have fallen skiing. And the patient was very clear. They said, no, I slept at my friend's house the night before skiing and the pillow was really uncomfortable. And I woke up with really severe neck pain and I went skiing. So it wasn't the skiing, it was just lying funny on the couch. Roller coasters, coughing, chiropractors. There's lots of ways to get a cervical artery dissection. So you asked, Valeria, should there be other neurologic symptoms? Not necessarily. So the artery has pain-sensitive structures in it. And so a tear of the artery, so arterial dissection here is a split between the, I believe, the intima and the media of the artery. So you're not bleeding out from the artery, but bleeding into a false lumen or dissection flap. That's painful. One of your arteries to your brain has torn. The body doesn't like that and it causes pain. And it won't cause neurologic symptoms necessarily unless one of two things happen. So in the carotid artery, once that dissection flap is torn open, blood flows into there and the dissection flap can progress and the artery can be expanded and the lower cranial nerves are there. So you can get cranial nerve 9, 10, 11, 12, or a Horner syndrome. Horner's is the most common in my experience from a carotid artery dissection, but without a stroke. The vertebral artery is pretty well tucked into the cervical spine, and the vertebral canal has its nice little sort of location built for it to travel up to the brainstem and cerebellum. And unless you get infarction, you might not have other neurologic symptoms beyond pain. And so how do you get infarction in those cases? There's sort of two hypotheses. One is that the blood flowing into the false lumen expands the dissection flap to the point that blood can no longer pass well through the main lumen of the artery, and there's sort of hypoperfusion. The more favored hypothesis is just that flapping dissection flap is very thrombogenic, and so it's prone to clot forming and then going upstairs to cause infarction. But some patients just have the dissection and they haven't had the stroke, and if this turns out to be what's going on here, we can have a very long conversation about the very complicated data about what you're supposed to do about that. And we won't go down that rabbit hole quite yet unless this is a dissection. We need to know what to do about it. But yeah, this patient could have a cervical artery dissection. I'm not sure we know quite about the characteristics of the pain there enough to distinguish that just from the patient hit their head and whiplash their neck, but maybe Gabby or Doug can opine as well. In my experience, patients who have this, it is very severe pain. It doesn't feel musculoskeletal to them. They feel very severe pain. You'd like to think it's pulsating or something to tell you it's vascular. Not usually that, but patients say it's a very severe pain. Doug or Gabby, I'm sure you've seen hundreds of these also. Any thoughts on the actual pain syndrome of a carotid or vertebral dissection?
When I've seen it, it's really variable. Like you said, there's not a great signature. One interesting thing I've seen with it too is that the pain could come back in the subacute period. Like they can get better with some analgesics. And then I have had one particular patient I've seen 3 times in the emergency room over about 4 months because they've come back because their migraines, actually they had migraines, their migraines come back, but then they have that same referred pain or pain referable to that same side of their neck where they had the vertebral injury. And it comes back and they require treatment again for it. So it can take a long time to heal, and it can really be variable. But I agree, I wish there was a good signature for it. Sort of like I wish there was one for cerebral sinus thrombosis, but unfortunately there isn't.
It is said with cerebral venous sinus thrombosis that if you ask the patient where the headache is, that they will point right to the sinus with great precision. I have seen that a few times. I was just reading, as Doug knows, De Jong, and he debunks that, or it's not him, it's whoever is writing that book now, says this has been commonly described. It's not accurate at all. But I have seen patients where you say, where is the headache? And they point here and they have a transverse sinus thrombosis, and it's very striking. And the pain of venous sinus thrombosis is another kind of pearl passed on from Marty Samuels, one of my mentors, that it goes away almost instantly when you start a heparin drip, that there's something either anti-inflammatory about heparin or something. Anyway, these are kind of anecdotes from the great sages of neurology, but modern texts sometimes say they're not that reliable. But no reason this patient should end up with a venous sinus thrombosis just from hitting their head. If there is head trauma, I think that can be one of the provoking factors, but you wouldn't expect suddenly for them to have a thrombosed sinus right as they get out of the car. Okay, I think we've gotten what we can out of that aliquot. So we're wondering, is this something mundane? Like mundane, I don't mean not interesting or not concerning, but sort of everyday, that the patient just bumped their head and twisted their neck or flipped their neck around and has some musculoskeletal pain. There could be any kind of hemorrhage inside the head. There could be a cervical artery dissection. So I'm not aware of any good guidelines that would tell you when to go looking for a cervical artery dissection in a patient who hasn't had a stroke. Where I trained, the ED, the emergency room was sort of tuned into this and often went looking for it, and we'd get consulted because they found it, and we'd ask, why did you go looking for this? Oh, well, the patient had trauma. We were scanning them from head, to toe anyway. It's not entirely clear what to do with it when you find it. But if this patient really had severe head and neck pain as part of this and the exam's normal, we don't have anything, would you add a CTA to that? You would think about it, a CTA or an MRA. Okay, can we have another aliquot, Rafa?
Sure. The reason I didn't tell you about the past medical history, medications, family history, social history, is because all of that are unremarkable. This patient has no past medical history, no medications, no relevant family and social history, health-related behavior, or allergies. Okay, so we did a neuroimaging that was unremarkable, except for evidence of a right transverse foraminal fracture at the level of C2, and the patient was placed in a cervical collar and admitted to the hospital. However, on further examination, this patient developed some complications, and I'm going to give you just the initial vital signs. Temperature 37. Blood pressure 150/90. The pulse was 85 and respirations 13 per minute. And those complications obviously are neurological ones that I'm going to be exploring in the next aliquot.
Okay. I don't know if Boris came back. Do you want to discuss any of this? No worries if not. Otherwise, Valeria, it's you and me again. Are you there, Boris? Would you like to tell us what you're thinking at this stage? All right, you're up again, Valeria. You got your imaging, and Rafa is withholding further information.
Yeah, I'm not sure because, I mean, okay, so the transverse foraminal fracture, I think, I mean, that could explain the neck pain. But the vital signs are striking to me because of the hypertension. I think that's very important because, I mean, for one, it could be part of the Cushing triad of intracranial hypertension. And that's definitely, I mean, we have not seen any other signs, but we don't have the exam yet. So, I mean, we don't see any like bradycardia or, well, we have actually a very slow respiratory rate. So I think we have maybe 2 of 3. And hypertension with low respiratory rates. I mean, I would expect maybe a greater respiratory rate for this patient. Yeah, that's something that really makes me alarm of the possibility of something expanding the intracranial pressure. But we don't see any more on imaging, so I really don't know what to do at this stage. I think, I mean, I know if I have a suspicion of subarachnoid hemorrhage or something like that, that I need to rule out because of the need of instant treatment. I will do an LP post 12 hours of the onset of symptoms, but I'm not sure if that's my principal suspicion here. So I'm not sure what you think.
Yeah, great thoughts, Valeria. I think, yeah, C2. Okay, I saw someone had written T2. C2 makes more sense here. The thoracic spine is pretty immobile, so it's hard to get too much pathology there in terms of things related to movement, right? The discs tend to herniate at C6, 7, and C7, T1, and the lumbar spine, L4, L5, L5, S1. But you rarely see disc disease in the thoracic spine, though there are the most thoracic vertebrae. So whenever you see these studies saying TB is more common in the thoracic spine and metastases are more common in the thoracic spine, there's just more thoracic vertebrae. So I'm not sure they particularly like that part of the spine, or it's just probabilities. But yeah, so you picked up on that hypertension, and Rafa wanted us to pick up on that because otherwise we'd be really interested in the neuro exam, right? So Cushing's triad, which we all learn about, hypertension, bradycardia, and change in respiratory pattern, is usually at a pretty advanced stage of herniation, right? You're really getting compromise of the brainstem. So it'd be pretty atypical for, we don't know yet, but we assume this patient is walking, talking, awake. And so for that patient to also have vital signs that we would attribute to Cushing's triad would be pretty unlikely. These are usually comatose patients who are sort of going over the edge of herniation. Any other, and the respiratory rate, I remember when I was an intern, everyone's respiratory rate was 16, and that was just sort of what everyone wrote in the chart, and the senior resident said, I want you to actually count the respirations. Nobody's respiratory rate is 16, that's just the average. So I'm not that worried about 13 necessarily, unless Rafa has some big surprises for us in the next aliquot. This patient's just maybe got some pain medicine and is breathing a little bit lower, but definitely that hypertension is not normal for a healthy 35-year-old. Any other reasons you can think of, Valeria, that would cause the blood pressure to be up aside from Cushing's triad?
I mean, what comes to mind is autonomic dysfunction, but I really don't think this fits this case. Like I've seen it in, for example, cases of Guillain-Barré or autonomic encephalitis or something like that, when we see autonomic dysfunction. But in this case, maybe it's just part of the stress response of the patient after going through a trauma, as you pointed out.
Yeah, so it could be from pain. And then another thing, I don't want to get too stuck on our hypothesis of a cervical artery dissection, but if you fracture a cervical vertebra, well, that vertebral artery is running right through there. So it could certainly be compromised, either compressed by bone fragment or dissected. And if the patient's blood supply is not making it through one of the 4 arteries heading up to the brain, it's possible that the hypertension could be a response to some mild hypoperfusion. But that's me sort of sticking with the hypothesis, maybe to getting a little bit anchored on that possibility. So I think Rafa has suggested to us some other things are going to happen here that might give us some more clues to localization and diagnosis here. So we're going to this thinking the patient could have cervical fracture causing pain and pain causing hypertension. He said it was a simple case, so that would be simple, right? Or if there's some more kind of neurology here, is there a vertebral artery dissection and then secondary hypertension trying to perfuse the brain? Or is this exam about to have a bunch of neuro findings suggesting that the patient did have a stroke from this, and because of that ischemia, that the brain is asking for more blood pressure? So what happened next, Rafa?
Okay, so on the neuro exam, this patient is found to have dizziness, right-sided facial numbness, and hoarseness. Also, neurological examination shows a partial ptosis and meiosis of the right eye, as well as nystagmus. The hearing is intact bilaterally. However, there is reduced sensation to pain and temperature on the right side of the face and the left side of the body. And this patient is also ataxic and displays past pointing with her right hand on finger to nose testing. And that's the end of the article. We have just one more imaging that will reveal the diagnosis.
Okay, so I guess it was just bump on the head and whiplash, huh? Simple case, like Rafa said. No, it doesn't seem like it. Okay. Valeria, what are you going to do with all of these findings? You can answer individually first or with one word first, since I saw you smiling as you heard them. Oops, you're muted, Valeria. We're not getting to hear your brilliant discussion.
No, I think, well, these are a bunch of focal signs, and definitely make me think of the vertebral and basilar circulation. Because of the right-sided facial loss, pain and temperature, of course, pain and temperature because of the rule of force is located laterally, and so also the 7 is located in the pons, and we have also partial ptosis and meiosis, and I mean that's also like the sympathetic tract is located in the lateral side. And yeah, I think, and yes, the decreased pain and temperature in the left side of the body, and also some cerebral signs. So I think that this definitely is more localized to a lateral medullary syndrome, I think. And so, yeah, I really think that the hypothesis of dissection is more strong now.
Yes, excellent. So there's so many findings here, right? And I saw lots of smiling, and I saw recent step 1 takers nodding their head as each sign of this syndrome was listed and going through like a checklist. And I didn't want to spoil it, but I wanted to write in the chat, paging Dr. Wallenberg, because this is the lateral medullary syndrome, right? And you not only localized that beautifully by the pattern recognition, but explained a lot of the important features, which allow for a good review of brainstem anatomy, right? So brainstem is super complicated anatomically, and so I try to break it down into a couple of organizing principles. There's a ton of stuff in there, but I divide that ton of stuff into 4 categories. The first category is the long tracts, meaning the corticospinal tracts, dorsal columns, and anterolateral tracts that are traveling between the brain and spinal cord. The second are the cerebellar peduncles, the 3-paired cerebellar peduncles that communicate between brainstem and cerebellum anatomically, but really between cerebellum and the rest of the nervous system functionally. There's the cranial nerve nuclei, everyone's favorites. And then there are the diffuse neurotransmitter projection syndromes like the locus ceruleus and the substantia nigra and the reticular activating system and all that good stuff, which we don't really think about clinically too much, although it's what's allowing us to be awake and attentive and enjoying ourselves right now. So that's one organizing principle, that there are 4 things, 4 categories of things, right? You might have heard of this rule 7 plus or minus 2 for memory, right? One of the old memory studies that people can remember a string of digits about 7 plus or minus 2. And then people say, well, then how do you memorize like everything in medical school? It's more than 7 plus or minus 2. It's because you keep making categories, you keep chunking, right? So if you say, well, there's 4 categories of things in the brainstem, that's easier. So then if you look at the cranial nerves, particularly, Valeria mentioned the rule of 4s. So you can basically think 1, 2, 3, 4, midbrain, 5, 6, 7, 8, pons, 9, 10, 11, 12, medulla, but there are some exceptions. 1 and 11 don't go to the brainstem. 5 has nuclei at all 3 levels. The mesencephalic nucleus of 5 for jaw proprioception in the midbrain. Who cares? There's really no clinical relevance. That's neuro trivia. The pons has the main or chief or principal sensory nucleus of 5 for light touch to the face, and it has the motor nucleus of 5 for the muscles of mastication. And then cranial nerve 8 is a partial exception because it sort of straddles the pontomedullary junction. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 actually becomes 2, 3, 4, 5, 5, 6, 7, 8, 8, 9, 10, 12. But basically, more or less works. And then the other organizing principle is knowing what's medial and what's lateral. So what's medial in the long tracts are the corticospinal tracts. Those are the most anterior and ventral thing in the brainstem. And the dorsal columns and spinothalamic tracts, for the most part, are dorsolateral. Briefly, the medial lemnisci are medial in the medial medulla and the lower medulla, and then they sort of migrate laterally. Then for the cranial nerve nuclei, and having too much fun talking about the brainstem, sorry. I'm getting hoarse to demonstrate the 9 and 10 palsy. All right, I'll mute so you don't have to. Sorry, I already gave a lecture before this in Zambia, where I'm doing these early morning lectures, which are late afternoon lectures there. So already losing my voice today, and it's a little dry down here in the desert. Okay, as I was saying, motor cranial nerve nuclei are medial, and the sensory ones are lateral. So what are the motor cranial nerve nuclei? The purest skeletal motor innervating cranial nerve nuclei are 3, 4, 6, and 12. And I call this the motor elevator. If you were at the midline of the midbrain and got on the elevator in the cranial nerve 3 nucleus, you would descend below that to the cranial nerve 4 nucleus, and the pons to the 6 nucleus, and just below that, right at the midline, to the 12 nuclei. Now, slightly more lateral to that are what are called the bronchial motor cranial nerve nuclei, which are motor 5, 7 in the pons, and then 9 and 10 in the medulla. And those are motor, so they're sort of medial, but they're bronchial motor, which embryologically, bronchial arch is something I don't really remember, but they ended up slightly more laterally. And then most laterally are 5, sensory 5, and 8. And the cerebellar peduncles are out there as well. So if you see a brainstem syndrome that has a lot of sensory, special sensory cranial nerve stuff, no motor stuff, you're lateral. And if you see one that has a lot of motor stuff, you're medial. And the other clue Valeria mentioned here is crossed signs. The STEP loves cross signs. In real life, Doug, Gabby, correct me if you've had a different experience, not super common to see a cross sign brainstem presentation. It's interesting when you see it, but not as common as just seeing MCA, PCA, MCA, PCA over and over again in terms of strokes. But the cross signs are because the corticospinal tracts on the way down have not yet crossed. The spinothalamic and dorsal column pathways on the way up have already crossed. And the cranial nerve nuclei are all projecting ipsilaterally, except cranial nerve 4, which is the only one that projects contralaterally, but there's no real clinical relevance to that. Which means that if you have a lateral brainstem syndrome, you can get cerebellar stuff, you can get sensory, special sensory, you shouldn't get any motor stuff, except 9 and 10, as we see in this case, which are a little more lateral because they're bronchial motor. On the other hand, if you had a medial brainstem syndrome, you would get the motor cranial nerve nuclei, 3 in the midbrain, 6 and 7 in the pons, and 12 in the medulla, and you would get contralateral stuff in the body. So do you know, Valeria, how to explain the patient's pain and temperature loss on one side of the face and opposite side of the body anatomically in this case? You already got the pattern, you already got all the good stuff. So this is just another little level of detail.
Maybe because of the I lost the word, but like the cross of the track, of the motor track under the pyramids, and so if it's above, we will see the cross line.
So you're correct if we saw weakness, right? That for the whole brainstem, weakness would be contralateral. How about for pain and temperature? Same principle, different tract, different crossing.
Yes, because we see, okay, so the cross line is from the face and the body. Okay, because of the, I think because of the cranial nerve 5, it's the one that is gonna give the sensation in the face, and versus the sensation and pain, temperature, and everything, it's gonna be the spinal thalamic tract, and so that will be going down.
You got it. You got it. So the pain and temperature for the face is one of the 5 exceptions. For some reason, it enters at the level of the pons, like the rest of the 5 stuff, but it descends to the medulla, even to the upper cervical spine, and then crosses over and comes back up the other side. That's called the spinal nucleus and tract of 5. So pain and temperature, just like for the body, is split off from the other sensory modalities, and it sits in the medulla. And then the spinal thalamic tracts, remember, those cross essentially immediately after entering the spinal cord, in reality over about 2 to 3 spinal levels, and they're contralateral the whole way up. So spinal cord, brainstem, brain, you get that, a lesion of that pathway, it's contralateral pain and temperature loss. So if you get a lesion in the lateral medulla, you get the nucleus of 5, which would give you ipsilateral pain and temperature loss in the face, but you get the already crossed spinal thalamic tract, which would give you contralateral pain and temperature loss in the body. Now, once I was teaching this anatomy very early on in my early times teaching anatomy to medical students as a resident, and a student said, so you said there's the spinal nucleus and tract of 5, they're getting that pain and temperature, and it's coming down and crossing and coming up the other side. So doesn't that mean the one you're talking about in lateral medullary syndrome also has the pain and temperature for the face from the other side right next to it? Why don't you get bilateral facial weakness, or why don't you get bilateral facial numbness to pain and temperature, or contralateral? And I said, actually, yeah, why don't you get that? And so I asked the director of the course, and he said, yeah, I learned that from a student asking me and not knowing the answer also, and dug out some old paper that actually showed that in lateral medullary syndrome, a certain % of patients have cross signs, a certain have bilateral facial pain and temperature loss, and a certain have pain and temperature loss in the face and body on the same side. So it's like anything in medicine, there's the pattern recognition, and then once you peel one layer of the onion, sometimes there's a different vegetable inside, right? A completely different situation. I've seen a lot of, not a lot, I've seen a fair number of lateral medullary syndromes, usually with the cross signs. Have you, anyone, or particularly Doug and Gabby, who neurology residents or recent graduates of residency, seen any other patterns of lateral medullary with bifacial pain, temperature loss, or everything on the same side? It's been reported, but I haven't seen it. No from Doug. I don't see Gabby on my screen.
Yeah, I lost my camera, but I haven't seen it either.
You haven't seen it either. So there you go. Been reported, but hasn't yet been seen by our cohorters. Has probably seen a few thousand neurology patients between us. Okay, last question, Valeria. Sorry, you're on the spot for everything today, but if this is lateral medullary syndrome, which artery do you think is affected?
Oh, the PICA, the posterior inferior cerebral.
Yep, and what does that arise from in most people?
From the vertebral circulation.
Yeah, perfect. So we have these 3 paired circumferential arteries coming off the vertebrobasilar system, SCAs at the midbrain level, AICAs at the pontine level, and PICAs at the medullary level. And there are lots of variants to this anatomy, but in general, SCAs, AICAs come off of the basilar, and the PICA or the pica comes off of the vertebral. So all that talk I gave before, and Maria had to keep changing the font size to get it all in there about the brainstem. When I teach this, I often say, well, so why should you care about these medial lateral syndromes? And the reason is this: if you have most of these syndromes, I should say, well, actually I shouldn't say that. Most of these syndromes, when we see them now, are seen in a vascular context. Though the ones in the midbrain, Weber, Benedict, and Claude, which are third nerve nucleus plus corticospinal, third nerve nucleus plus, I think, red nucleus, and third nerve nucleus plus superior cerebellar peduncle. So third nerve palsy and contralateral weakness or movement disorder or ataxia. I pulled one of the original papers. Someone found it for me, or I found it for Benedict. And I think it was Benedict. And the lesion was a tuberculoma in the midbrain. And his description was on pathology. It was the size of a pigeon egg or a goose egg or something like this, back when you could be very poetic about pathological findings. So not all of these were described in the vascular context. And there's a wonderful paper we can send around where someone went back and looked at the original descriptions and showed how messy they are because the brainstem is so small and intricate. But Weber, Benedict, Claude, and Nothnagel or something, there's another one. Anyway, when we see these in vascular context, back to the point I was going to make, but I got excited about the goose egg tuberculoma in the midbrain. When you have a medial brainstem syndrome, say a medial pontine or a medial midbrain syndrome in particular, the vascular lesion is usually a small penetrating artery coming off of the basilar. So these sort of penetrating arteries, and those penetrating arteries that come off as sort of a perpendicular to the basilar tend to be affected more by hypertension, lipohyalinosis, the sort of lacunar physiology, pathophysiology, if you will. Whereas the lateral syndromes, those are very distal in the circumferential arteries. So pica syndrome here, we're pretty lateral, right? When we won't see the image, Rafa told us, or maybe we will see the image, I forget, but very lateral, and you can often get the cerebellum. And it would be relatively unlikely to have atherosclerotic plaques that distal in one of these smaller arteries. And so those should make you wonder about embolism. Now, if you see embolism in the SCA or the AICA, you're probably thinking of something coming from the aortic arch, from the heart, or possibly from the vertebral system. But because the vertebrals are actually pretty lateral as they are sitting over the medulla and give off the pica, infarctions are almost always due to, I shouldn't say that, pica infarctions are often due to vertebral pathology, though it's the first exit off the highway for an embolism coming up from the heart also. So all that to say, if you see a sudden onset medial brainstem syndrome, you would probably be thinking more about hypertension as an etiology and less about embolism, so more thrombotic disease than embolism. And if you see a more lateral brainstem syndrome, in general, this isn't a perfect rule, you'd be thinking more about embolism, though in the medulla, it gets a little bit cloudy because of vertebral artery occlusion from vascular risk factors or from dissection could block the takeoff origin. There's a word I'm looking for that I'm not coming up with. Doug can probably guess what I'm thinking. The takeoff of the pica from the vertebral. It begins with an O, I think. I don't know. I'm having a moment of Broca's aphasia.
The ostia?
What was it?
Are you talking about the ostia?
I don't know. I don't know what I'm talking about. You know what I'm talking about.
Well, I can't read your mind if you can't.
That's fair. The ostia, what am I looking for? I don't know. The beginning of that artery emerging from its parent artery. There's a word for that, and I'm not remembering it. And C. Miller Fisher is frowning from heaven on all of us. Okay, so we think, Valeria thinks, and I agree, this is lateral medullary syndrome. She even picked up that the patient has Horner syndrome, and that's because the oculosympathetics run in the dorsolateral brainstem, all the way down to C8T1, come back over the lung apex, up with the carotid. Maybe we'd even find a lack of sweating on one side of the face in that patient, but that's very hard to detect. And we think, given the context, that this was probably a vertebral artery dissection. And let's hear from Rafa what you found, and then we can spend a few minutes if people want, although we'll probably run over if we get onto this topic, talking about what the heck you should do if you find a stroke in a dissection, because it is not straightforward.
Okay, so case resolution, we did a vascular imaging that showed acute vertebral artery dissection. And this combination localized to the lateral medulla and lateral medullary Wallenberg syndrome was diagnosed. And it is commonly caused by occlusion of vertebral artery or one of its branches. And one thing to remember why I brought this case is that cervical spine trauma can cause dissection of extracranial vessels like the carotid vertebral arteries, causing ischemic stroke in young patients.
Fantastic. So yeah, there's a series from Helsinki from I forget how many years ago, probably 15 or 20 years ago, of cases of stroke in patients between age 18 and 49, I think. So young onset stroke. When patients are older and have stroke, although I like to think of patients chronological age and then their kind of medical age, because some patients are in their 80s and running marathons and have no health issues and they're medically sort of young, right? And some patients who are younger have vascular risk factors. So looking at causes of stroke in that Helsinki cohort, the most common etiologies of stroke, even in that young group, were vascular risk factors, the usual hypertension, diabetes, cholesterol, smoking. But if you take those out, the two most common causes of stroke in young people were cardiac arrhythmias and cervical artery dissections, is my recollection of that study. So if you have a young patient with a stroke, there's a whole list of things you would look for, but one of them would be dissection. With the vertebrals, it can be hard to diagnose. The place where it usually gets dissected is right where it makes a kind of turn. I always forget the names of the segments, but as it leaves the cervical spine and it punctures the, forget if it's already punctured the dura or not, but it makes kind of a right angle turn. And when you're looking at that on axial slices, that's a place where it's sort of susceptible to getting injury. And so it can be a little hard to pick that up. And sometimes the radiologist will miss it, or they'll say, and it's also common for the vertebral arteries to be very different on the two sides. The carotid should look exactly the same unless there's pathology. Although someone once showed me a case of someone with congenital absence of one of the carotids. They were totally fine. It was an incidental finding. But usually the carotid should look exactly the same, if not they're pathological. The vertebral arteries, on the other hand, are often very different. Patients have a dominant vertebral artery that's much bigger and a smaller hypoplastic one on the other side. So if the patient dissects the hypoplastic one, it can be hard to tell, was that small to begin with? And so the caliber is small. Sometimes you can look at the vertebral canal on the vertebra and they have different sizes, although a radiologist told me that's not a perfect rule either. So Rafa, how did you treat this patient? Because this is a controversial area and what you're actually supposed to do.
I'm so sorry, I don't have that information. These are all the information. Yeah, I read that on a chart and I couldn't find it, what they did to the patient.
That's good to that's good that you couldn't find it, because whatever you do is controversial. So you've avoided controversy. Good. So why is this controversial? So what time is it? Oh, we're before 10. So I'll start talking and then I'll watch the number of participants start to slowly decline as we talk about dissection, except for probably Gabby and Doug, who will, I'm sure, have their own ideas about this. So when I was a resident, I always thought it would be funny that I'd be saying that one day, but it was not that long ago. There were not randomized clinical trials about this topic. Now there are, but the problem still persists. So if a patient has had a stroke, and if the patient had the stroke in the hospital here, maybe they got TPA, and that would delay the next question for some time, or that maybe they got a thrombectomy, though a thrombectomy can be very difficult to get through a dissected artery. You don't want to put the catheter in the false lumen, especially in the vertebral artery. You can get into big trouble there. So before the IST and CAST trials, which were in the late 90s, that showed that for acute stroke, aspirin is really helpful. It decreases the risk of a second in-hospital stroke and decreases mortality, and showed that heparin was not helpful. Before that, if someone had a stroke, they mostly got heparin. And where I trained was Mass General Hospital and Brigham and Women's Hospital, and they're linked, but they're sort of different culturally. And people used to joke that Mass General Hospital, MGH, stands for must give heparin for stroke, and Brigham and Women's Hospital stood for better withhold heparin for stroke. So as a resident going back and forth, there's still some history there on what to do. But a lot of patients got heparin. The physiology makes sense, right? There's some blood clot and you're trying to thin it out, and that's what we do in the heart. And a lot of stuff we do in the heart, for whatever reason, doesn't work in the brain. And dissection was one of those areas where the thinking was, as I mentioned before, that dissection flap is very thrombogenic. And so what's the pathophysiology of stroke in those cases? It's artery to artery embolization, and that heparin should reduce the risk of that. And some people said, well, aspirin is an antithrombotic. It's probably just as good, and there's lower hemorrhage risk. And when I was a resident, the only data we had to go on was a big Cochrane review that was almost all studies for the carotid, not the vertebral, that suggested that they were about equivalent, that you could use either aspirin or anticoagulation. There's a luminary of neurology, Lewis Kaplan, who's at Beth Israel in Boston, who studied with C. Miller Fisher. Anytime someone publishes about dissection, you can wait, and this is not like the social media age, he's probably in his 80s or 90s, but there will definitely be a commentary on that paper by Lewis Kaplan, who will say, I don't buy these studies, because by the time the patient made it to the hospital and they figured out dissection, it was too late. If you see a dissection and a stroke, that patient needs to be anticoagulated immediately. And he always says, I've seen thousands of these. This study only has a few hundred. I have more experience. And this is how this works. And you should be giving anticoagulation for all these patients. In 2015, finally, after I graduated from residency, a study came out called CADIS, which compared aspirin and anticoagulation for cervical artery dissection, both carotid and vertebral. A very important point about that study is that is largely a secondary prevention trial, meaning that the patient had a stroke, was found to have a dissection, and then was randomized to aspirin or anticoagulation. A very small percentage of patients enrolled had a dissection and had not yet had their stroke. So we really don't know what to do with those patients. And if you believe Lou Kaplan, and I tend to, because these are usually young, healthy patients who can tolerate anticoagulation, if I see a patient with a dissection who hasn't yet had a stroke, in my head, I know this is not how we're supposed to do this. I think of all the young patients who had strokes from their dissections, and I anticoagulate them. What did CADIS show? Showed that if you've had your stroke and the etiology is dissection, turns out the recurrence risk is really low for another stroke. It's about 1%. And so it's really hard to show a difference between the two groups. And I think they enrolled for years and only got 200 patients. They showed no difference between aspirin and anticoagulation. And the editorial that went with the article said they would have had to randomize 5,000 patients to each group to show a meaningful difference. So people interpreted this as saying, oh, they're the same, we should use aspirin, it's safer. No, if they're the same, you could use anticoagulation, it's equally safe. So we actually don't really know the answer there. The stroke gurus I've talked to and I trained under have generally said, as I just did, that if a patient has a dissection and you pick it up at the moment of neck pain, and they haven't yet had their stroke, there's some old French studies that show that most patients who remember when the neck pain started, the strokes are almost all within the first 24 to 48 hours, and there's a tail down to about 7 days, and it's very rare to have a stroke after that. There's this sort of early window where it's worth anticoagulating these patients. And if you've ever seen a really bad one, I saw a young, healthy guy just keep having stroke after he presented with a TIA, he had a dissection, we sent him for an MRI, and he came back from the MRI with a stroke while he was anticoagulating. We actually wrote this case up, we hypertensed him, we did all kinds of stuff. He just kept having strokes. When these are bad, they're bad. And heparin in the acute setting, again, I'm not going on data here because it's ambiguous, but what I've learned. And then a short course of anticoagulation, 3 to 6 months. Most of these are young, healthy patients. You tell them no mountain climbing, no bungee jumping, and they do fine with anticoagulation. Did you protect them from another stroke? You don't know. But you would be perfectly within the data to say, I give aspirin to all of these patients. Once the patients had their stroke, there's this idea that according to that data, the risk of another one is super low, it's 1%. And the data suggests I could give either. I've seen a few young, healthy patients go on to have a second stroke, and it sticks with you when you see that. I've seen it happen through anticoagulation. I've seen it happen without. So I tend to be more aggressive and anticoagulate these patients. But Doug and Gabby, what do you do with a dissection, a stroke caused by a dissection, so the stroke has happened, or a dissection and the stroke has not yet happened? Those are, to me, two different scenarios with a lot of data for the first one and not for the second one. What do you do? This is like one of these neurologist like a wrestling match situations. People get very worked up about this.
Gabby, do you have any thoughts first?
Yeah, actually, every time that I see a patient with these conditions, I go back to study. And every time I don't see when I don't have a final decision, and it's so uncertain. And last time that I saw it, I think it was like one year ago, and I think we anticoagulated the person. but it's something that I always read, and I'm waiting for a final conclusion, actually. I'd love to hear your thoughts, though.
Yeah, like most areas of medicine, the more you read, the less you realize that we know. Yeah. What's the culture in San Francisco, Doug?
Yeah, I think, Aaron, you highlighted beautifully how difficult this territory is. And Gabby, I agree. I feel like I go back and sort of start from an early square. I don't know if it's square one every time, but an early square every single time, and reconfuse myself, and then talk to a lot of people. And one of the, and Aaron, we go through a lot of the same thoughts that you kind of pointed out. Have they had their stroke yet? One of the things that I've been taught to think about, but I don't know if this is, I actually don't know if this is in any of the data, is whether or not it's an intradural or extradural dissection. And it's something, there's not that many, because, it's hard to imagine exactly what aspirin is doing and exactly what anticoagulation is doing to a local source of thrombus. I usually think of aspirin as being the more, pathophysiologic way of addressing like a local thrombus. If you're thinking about a small vessel stroke, you think about aspirin more than anticoagulation. And if you're thinking about thrombi and potential thromboemboli forming in the heart of the aortic arch, you think about or people with hypercoagulable states, you think about anticoagulation. So aspirin kind of made more sense to me. I know that that's kind of just my own thinking, but the thought about where it is, if it's extradural and you bleed, because dissection is on the differential for a subarachnoid hemorrhage or a spontaneous bleed. I know they don't bleed very often, but if someone bleeds and it's in their neck outside of the dura, they have a small contusion that can usually be drained, or it doesn't kill them. But if it's inside the dura, then they could have a subarachnoid hemorrhage. Granted, it's usually a mesencephalic subarachnoid hemorrhage, which is has a better mortality profile, but it's still it's an ICU stay. It's a very morbid complication. So that's often something I think about. And then the other branch point, so intradural, extradural, and then the other branch point is like, has it caused a stroke or has it not caused a stroke, which does not get to the point which you made about preventing the stroke in the first place. But there's some thought that, certain dissections are more, embologenic than others. So, there's kind of a four-way table that I think about: intradural, extradural, associated stroke or no associated stroke, acknowledging that doesn't get to the place where you want to make the difference, which is, how do you prevent the stroke? So.
Yeah. So you highlighted another point where the data is a total mess, which is, does the dissection extend intradurally or not? The idea being, as Doug said, if this artery is fragile and dissected and it goes now not just through the intima and media, but through the externa, which really shouldn't happen if this is a dissection, which is part of the mess here. If that happens intracranially, you're in big trouble. You have a subarachnoid hemorrhage. I think there's only one series that looks at this, and it also has a lot of letters to the editor afterwards, because this is a controversial, this is what neurologists get worked up about. And I can send it around. But they suggested that actually the patients who have an intracranial dissection usually present not with stroke, but with subarachnoid hemorrhage, and you wouldn't even think of anticoagulating them to begin with. And if it's an intracranial lesion other than am I getting this backward? I think the paper essentially says, it's been a long time since I've looked at it, either patients present with stroke or with intracranial, with subarachnoid hemorrhage. And if they don't present with subarachnoid hemorrhage and you think it's a dissection, it's probably safe to anticoagulate them. And then the letters to the editor were saying, I looked at your CTAs and I don't think those were all dissections. Some of them might've been stenosis, or those are really small vessels to decide whether it's a dissection or not. But even that point, that could be a branch point, is also ambiguous. So I think your 2x2 table is good. If you say, well, the patient already had their stroke, we have the CADIS trial, and it's intradural, I'll probably be okay with aspirin. That feels safer, but the data doesn't actually support that it is safer. And if it's patient hasn't had their stroke, we're really in a data-free zone. And if they have, we can use CADIS. But yeah, it's a little bit tricky. Your point about the type of clot, I think Lou Kaplan would debate. He, in these responses, he always responds to the CADIS trial with some letter to the editor. And when he talks about red clots versus white clots, and that, I forget which is which. This is the type of clot that needs heparin is his idea, and they need it quickly. In the first publications around CADIS, they were saying the average time to randomization was 3 to 5 days. And he said, not a valid ask, right? Because not a valid question, right? That we want to be anticoagulating from days 1 to 3. That's that key period where this is a really dangerous condition. So Rafa said a simple case. That's why I'm making special points to make it extra long and complicated. I'm just kidding. One of my mentors who ran Morning Report, Marty Samuels, if the resident ever said, it was a boring night, I just have one boring case, he would always smile and make Morning Reports so long to show that nothing is boring. So I guess I'm channeling that. And we've lost 7 out of 24 as a result. But for those of you who stayed, I hope you've enjoyed watching Neurologist Happy Hour here. We haven't forgotten about you, Maria. You didn't want to write any teaching points about dissection because there's nothing clear to say. So go ahead and finish us off with your teaching points.
This was awesome. Yeah, I didn't write anything at the end because that would have taken like all of the PowerPoint. But really,
that's our goal. That everything else just gets pushed into one corner. That's all. Sorry, go ahead.
We do that all the time, and it's so funny that Rafa thought like neurologists are not gonna like really love brainstem and cranial nerves to go over that discussion. But we started very simply with headache. And with headache, the really important thing is that you don't want to miss the red flags, and definitely trauma is a red flag. So in that context, headache takes a complete different approach, and you really want to take do not dismiss those signs like they did in this case, because you can simply say like, oh, neck pain, headache, maybe a musculoskeletal spasm, and send this patient home and miss all of this. So definitely keep an eye on headaches when they are risky. Whenever you see trauma, you want to first think like the bleeding complications are the ones that we tend to think of the most. Patients are rushed to CT scans all the time, looking for like subdurals, epidurals, subarachnoid hemorrhage, intraparenchymatous hemorrhages. But there's also other things that trauma can cause, like we saw in this case, cervical artery dissections, things in the cervical spine, or maybe like even osseous like herniation, fractures, or listhesis that can cause complications in the long term. And then like you want to leave the musculoskeletal to like the end. So you want to really rule out everything first before you say, oh, it's a muscle spasm. And then in here, the patient had like very different signs that really show that this was not like a common muscle spasm. And truly, how do we locate to brainstem? Really think it's a heavy traffic area of the brain. So you're going to get like tons of cranial nerves, tons of like signs and symptoms in face and body. Typically, we tend to learn that they have cross signs, so ipsilateral to the face and cross-lateral to the body, but everything has exceptions. And what to do when you're already in the brainstem, think about 4 things. So the cranial nerve nuclei will give you tons in localization. So the rule of 4, you can think not 1, but like 2, 3, 4 to the midbrain, 5, 6, 7, 8 to the pons, medulla is 9, 10, 11, 12 with certain exceptions like number 1 and 11 that don't really go to the brainstem. Cranial nerve 5 does all of the levels, and cranial nerve 8 is in pons and medulla. And then also like now that you know like we're in the level, try to think lateral or medially. So lateral, think really about the sensory. Motor, think medial. Lateral, think sensory. Then you can also think about the long tracts. So medial are cortical spinal tracts, and lateral are the dorsal columns and the spinothalamic, and also the sympathetic tract, as we saw in this case. You can also localize with the cerebral peduncles, and also think about the diffuse neurotransmitter projections. And when we saw all of this, we knew we had a cervical artery dissection. And we knew it was causing Wallenberg syndrome. So really to like go over Wallenberg syndrome, the name stands for like lateral medullary syndrome, and it's caused by it can be caused by a dissection in the vertebral circulation affecting the posterior inferior cerebral artery. And it's gonna affect cranial nerve 5, which is gonna give you ipsilateral pain and temperature dysfunction in the face, like in this case. It's going to affect cranial nerve 8, which can give you vertigo and nystagmus, which we didn't have here, I think. It's going to give you affection of the nucleus ambiguus, which covers cranial nerve 9, 10, and 12. It's going to give you dysphagia, hoarseness, which we had here. It's going to affect the spinothalamic tract. It's going to give you contralateral pain and temporary dysfunction in the body, which we do have here. And it can also affect the inferior cerebral peduncles, which is going to cause ataxia, and the sympathetic fibers that can cause Horner syndrome. And so definitely, whenever you see trauma, try to think of this. And whenever you see stroke in the young, really think about cervical artery dissection and arrhythmias. And if you see a cervical artery dissection, then I don't know, because the treatment seems very confusing to me, but very interesting as well. So I really liked today's case, and thanks everybody who participated in it.
Fantastic, Maria. Thank you for bringing this quote simple case, Rafa. Thank you, Valeria, for discussing it solo with me. Brilliant discussion. You got to the diagnosis, I think, after the HPI, and thanks, Maria, for those teaching points. And I just put in the chat, whenever we had on rounds where I used to work with a big group of residents in Boston, whenever they saw that the case was going to be a dissection, they always looked around like, uh-oh, this is one of Aaron's favorite topics. He's going to go off on dissection and how the data doesn't make sense and what should we do? So I always remember people starting to smile and then shake their heads, uh-oh, it's dissection and Aaron's the attending. We should get comfortable and order some food. It's going to be a long day. And still we finished by 10:15. Great, thank you so much, everyone. Wonderful to see you. Am I here next week? I think I am. So if you have cases, feel free to bring them, but feel free mostly to bring yourself as a discussant. Valeria enjoyed discussing this case solo, but is eager for more discussants in the future. So see you all next Tuesday. Have a good rest of your day.